lead consultant at Birmingham Midland Eye Centre and chair of UKOA. A warm welcome to you all from myself and the UKOA team, Alison, Beale, and Heather. So today's meeting, the focus is on NHS England's commissioning guidance for medical retina, high-cost drugs, and we're going to talk about the specialist pharmacy services a little bit as well. There has been a reshaping of medical retina services with the introduction of biosimilars as first lines, and all of us are trying to strike a balance with this cost effectiveness and our clinical professional commitment of best outcomes for our patients. We are very privileged to have a panel today that covers the breadth of this topic, from clinical leadership that advised on this guidance to the commissioners, the ICB pharmacy medical optimization, feedback from clinicians as these guidelines are being implemented in the NHS services, and a small update from specialist ophthalmology pharmacy services. So first of all, thank you very much to our sponsors and the support that they provide with no influence on our activities. Thank you. Next slide, please. So a few housekeeping points from myself. Please stay on mute unless you're speaking. We have a dedicated Q&A session at the end of each presentation. So please raise your hand electronically during this session if you have any questions. Do provide us with your name and your role. It helps in answering the questions. We are monitoring the chat function. If you have any comments throughout the meeting, put them down and we'll get back to you if we can't during the meeting. We will kindly request you to put your email address, all the attendees, please, either in the chat box along with your organization, or drop us an email on UKOA mailbox so that we can note your attendance and send feedback form for which is so appreciated. This webinar is being recorded and it will be shared along with the slides on the UK website after the meeting. We will send all members a link because we do appreciate that colleagues and members are joining in between their work and clinical commitments. So that all this slide deck and this presentation will be available. Next slide, please. So this is our agenda today. As I was saying, it's broad, comprehensive, and balanced with sort of, end to end with the whole topic being covered. I would like each presenter to introduce themselves. That would be very much appreciated. Next slide, please. So a few updates from UKOA. We now have our schedule of meetings for the rest of this year, which is the last meeting for this year is November 2026. The details are on a slide a little bit later on. Very gentle, but please, on membership fee as well. We are having significant problems, so kindly check with your organization that they've paid their dues. We are very grateful to our sponsors, but for long-term sustainability of this platform, we really would like people to pay their dues. It gives the whole organization access to virtual meetings and first come first face-to-face meetings. And it also gives you access to our mailbox. The members are more than welcome to write information requests, clinical, non-clinical service queries. They have access to our website. It's an open source website at the moment with all the resources that we provide on it, including updates with all the meetings. It's an excellent opportunity for the members to showcase their success stories. We're quite happy to publicize events and any updates from departments on any changes in their pathways. So, please use the UKOA resource for that. The themes for the next few meetings are based on topics that have been requested by our members, and we considered a high priority with the changing NHS landscape. With UKOA's mission to keep all the ophthalmology sector updated and engaged in the NHS policies, strategies, with this spirit of collaboration. So please do put your thoughts and ideas of themes that you would like us to cover in future meetings, or any work that you want to share and you find that it will be very interesting to our members. Please put it in the chat box or email the UKOA mailbox. Next slide, please. So last slide. To tell us our upcoming events. So in July, we've got a collaborative meeting workshop with NHS England, where they're going to talk about and do actually roundtable discussions about neighborhood hubs with subspecialty glaucoma chosen as an initiating point. It is fully subscribed. However, if you wish to attend, you can drop us an email. We have got a waiting list and we'll let you know if there are any spaces. Then in September, we've got ophthalmology training, not only just AHPs, but our ophthalmology practitioner training program, as well as our optometric professional qualifications and trainings, 22nd of September. And then last for this year is updates from Northern Ireland for their ophthalmology services there. So without further ado, I will pass over to the very gentleman who led us regarding these, provided the clinical leadership and advisory for the National Ophthalmology NHS commissioning guidance. So over to you, Luke. Thank you very much.
Thanks, Bushra. And again, thank you everyone and UKOA for the invite to speak here. So I'm Luke Nicholson. I'm an ophthalmologist in medical retina, and my sort of involvement with this piece of work is I was part of the working group, and also I chaired several of the meetings. And hopefully I can share the next 24 minutes, share 90 pages worth of documents and information to the team. So hopefully you don't have to spend too long reading those documents. And also include some background as to how the background information that's relevant as well. So next slide, these are my disclosures. Good, so the NHS England guidance, it took a long time. It started with an expert working group, which consisted of clinicians, including consultants, nurse injectors, commissioners, pharmacists, the Royal College, Macular Society, and patient representatives as well. So it included quite a broad group of people who are involved with this. It took about 12 months. I mean, I don't work for NHS England, so I can't say the exact times, but that's my involvement. It took about 12 months. Looking at AMD, DMO, RVO, data collection, analysis, stakeholder engagement, etc., and principles that we wanted to work with. We subsequently published the wet AMD guidance. Again, this is commissioning guidance, it's not clinical guidance, and I think that's a very important differentiation. So again, the wet AMD guidance in late July, the webinar was held in August, and vein occlusion, macular edema in October, and DMO as well in October, with an updated guidance for wet AMD in October. So that's the general timelines that has taken place. Next slide. But why is there a need for national guidance? Well, there's multiple new treatment options. We didn't have this 10 years ago. We have a lot of different drugs. Now we have biosimilars and newer drugs with different prices, but different levels of durability, and how this impacts our choices and our finances is also important. We don't really have a lot of resources, and those in management will understand the amount of SIPs required from the trust and the amount of people losing jobs. It is very significant. And of course, the geographic variation. And I need to highlight that in 2022, there was national guidance on this, and that was to use ranibizumab biosimilar. And that was actually implemented in a number of ICBs, and a number of ICBs it wasn't. And that led to a huge deal of variation across the country, and why a more consistent granular guidance was basically asked for. Next slide. So the starting point of where we started work was ranibizumab was first line at that point, and that's how we started the discussions, which I'm glad we moved away from that. And again, anti-VEGF is key to highlight that it's not interchangeable. I think there's an animation here, but don't worry. Anti-VEGF is not interchangeable. You can't. All these anti-VEGFs are excellent drugs, and they're not all the same. Although they're classed as an anti-VEGF, there are significant differences between them. It's not a matter of a roulette in terms of which a patient gets. There are differences. There are safety differences, there are durability differences. So brolucizumab, for example, we know from published papers in real-world data as well as trial data in Hawk and Harrier, there's the highest risk of intraocular inflammation is seen with this drug. And of course, bevacizumab, on the other hand, we have a long history of data from the off-label use of Avastin, and that required the highest number of injections. So there are variations between these drugs, and they're not all the same. And you can see the intraocular inflammation rate from bevacizumab about 4%, aflibercept 0.3%, and Ongavia from real-world data in London with about 0.4%. And this is mostly anti-uveitis. Again, there are differences between these drugs. Next slide. And that's the animation. Okay, so what we're trying to deal with here is, again, I'm highlighting wet AMD in this specific slide, but it's to highlight that these conditions are serious. So wet AMD, for example, is an active growth of a blood vessel complex within the retina. And that sounds scary, and it is. You're having a growth of vessels that is uncontrolled, that's leaking and bleeding in the retina. The graphic on your right with the arrow is just a matter of 90 seconds to 2 minutes. And the white stuff that you see is basically fluorescein, which is the contrast injected to the bloodstream. That is how much is collecting in the retina every 90 seconds. And if you imagine walking around with a smudge in your glasses, imagine that permanently in the center of your vision. So these are significant problems for patients where timely treatment, not only in starting treatment, but in maintaining treatment is key. So we're dealing with something serious. It's not something to take lightly. Next slide. So again, I'm just going to fly through the drugs specifically and then go into how some discussions about how the decision's made. So ranibizumab, for example, I'm not talking about Lucentis, I'll talk about ranibizumab biosimilar. It's probably a low-cost option here. It's not the lowest cost, it's the low-cost option. And of course, high number of injections. And you look at trend, you look at tracks, you look at CanTreat in Canada, and you look at the NICE papers, you're seeing about 9 injections in year 1 and probably about 8 injections in year 2 if you are to treat the patient appropriately. And again, this is reflected in real-world data when we looked at Ongavia data in Kingston, which was predominantly a ranibizumab ICB. And again, you're seeing the variations between the efficacy. So at 4 weeks, only 76% are dry. The other quarter is active. So again, very different from faricimab, as you can see here. So there are differences between the efficacy of these drugs. Next slide, please. And then faricimab, so I'm going to the other extreme, is probably the highest cost at this stage, but the lowest number of injections. Again, this is based on the Tenaya and Lucerne data, the Morpheus data over 2 years, and of course the NICE papers. And again, you're seeing about possibly 6 to 7 injections in year 1 and about 4 injections or so in year 2. So again, it's the least number of injections if you were to pick an individual drug. And again, that's our data over 24 months. You can see that wet AMD is not a single, it's a disease, it's a well-known disease, but it's a huge spectrum in terms of response. Not everyone behaves the same. You can't prescribe someone 12 weekly intervals for everybody because a good portion will not do well with that level of treatment. Some will need more frequent treatment. So you can see the variations here, but you also can see about 27% stop treatment after 2 years. It's not a permanent lifelong treatment. Next slide. So what about clinical trial data and real-world data? Because I cited Tenaya and Lucerne, as you can see, the Tenaya and Lucerne data, and again, the UK Morpheus data that we've had over 2 years, it does show, it's not identical, but it does show a good level of durability compared to what we were anticipating, again, compared to other drugs. So there is value in this being a longer-acting drug. Next slide. Now, how about aflibercept 2 milligram? I've not talked about aflibercept 8 milligram because the real-world data to substantiate that is probably still in development to get more robust data, but we presume that that's going to be long-acting as well. So it's important just to mention that. So how about aflibercept 2 milligram? Well, the originator is probably the highest. It is the highest cost drug. I can't tell the exact prices, but you can talk to your pharmacist, or if you're a pharmacist, you know the past price, but it's very different from the list price. Now, the originator is the highest cost drug, but the biosimilar is the lowest cost drug. In some drugs, it's probably on par with the ranibizumab biosimilar. Injection frequency is probably moderate to low. So you see Vital It's 12 over 2 years. Shruti's paper done in Moorfields with Shobha, again, 12.7 to 13. You're looking at about 8 in year 1 and about 5 or 4 or 5 in year 2. Again, that's reflected in NICE, and Altair is slightly different because of the population, but you're getting the gist that it is still fairly low numbers of injections, but not the lowest compared to what we've seen before. Again, after 2 years, a good portion achieved 12-weekly intervals. Next slide. So again, the NOT data is useful, but we need to take into account majority of patients were on aflibercept 2 milligram or Eylea at this time. And again, the data, cleaning the data and making sure it's robust enough is also important. So we need to be aware that before we take this, we need to take it with a pinch of salt, basically, but it's something to be aware about. And this also feeds into discussions. Next slide. Now, the tricky part here is what's the best value drug for a system? So it's not just about that one person. Of course, you want to treat anyone with a golden ticket, the best care possible. That is great, but you have to treat the other 9 million people outside the door who's waiting for an appointment. So it's not as straightforward about who do you treat. There's a lot more in the system and what you can do with your money and how best to use it. So best value treatment, it's an easy graph here, which I have to say, I've taken the idea of the JFC team in NCL. So thank you for them for suggesting this approach. So if you look at the drug cost and the number of visits, this is sort of your table. And next slide. So your target, next slide. Oh, okay, there's no images. If you go back, sorry. Back again. Yeah, so the bottom left is where you want your target to be, meaning the lowest cost, the lowest number of visits, and you want to avoid something in the top right-hand corner. So of course, sadly, things don't work like that. Next slide, please. Sorry. In reality, the drug cost sometimes reflects the number of visits. The more expensive a premium the drug is, the less number of visits, because you're buying capacity to a degree, you're buying the less number of injections, and the cheaper the drug, it sometimes is more visits. So this, again, is not quite reflective. It doesn't help what we're trying to achieve. Next slide. Of course, where you want to target is somewhere in the green zone where it's reasonably lower cost, reasonably less number of visits. And it doesn't mean one drug to achieve that. You may have to consider 2 drugs to achieve that, but be aware of switching treatment and the capacity impact that has. Next slide. So I'm going to move to the guidance and go through the wet AMD, RVO, and DMO guidance. Next slide. So again, the whole idea of this is to use the biosimilar where beneficial, but also appropriately use longer-acting drugs, because again, not using that is not smart because it provides capacity relieving impact. So that's why you want to use that where appropriate. Next slide. And again. So again, now we start treatment. There's 2 groups, of course, NG82, which strongly recommends the use of treatment in patients better than 612. Next slide. I think there's some graphic at the bottom. Yes, so patients with good vision, this document strongly supports the use of treatment as opposed to the 612 cutoff that we had with NICE. It's important to highlight that back then in NICE, with the whole cost-effective calculations, it was all based on the originator price, but it's clearly said that if you have a significant discount, and of course with the biosimilars arriving, this then changes the whole cost efficacy of the drug, and thus it's recommended that we should start patients, because we know with NOD, the earlier we start patients at treatment, 80% of patients who start treatment with good vision, which is 612 or better, maintains that at the end of the year. And this is repeated over a number of years with different 2025 data as well. And 612 is the cutoff for driving. So you're literally waiting for someone to lose their ability to drive before you start treatment and unable to maintain that. So that doesn't really make sense at the higher socioeconomic impact. Again, NG82 supports that. And so we would strongly recommend it. I know it's not mandated, and therefore strongly suggest that this is reviewed in ICBs to suggest the use of it with the prices of the biosimilar. I think it doesn't make sense not to treat patients with that. Now, in terms of the treatment for patients with 612 to 696, then the starting point is in a aflibercept biosimilar or ranibizumab biosimilar in that sense. And again, harmonization is allowed. So if one patient has faricimab or 8 milligram in the left eye and the right eye develops new wet AMD, if the clinician feels the patient would benefit from what is used in the left eye, in the fellow eye, then it makes sense to harmonize treatment for a number of reasons. One, of course, for avoiding errors, and two, for ADR reporting, etc. The patient's on the same drug. So you can start the patient on the longer-acting drug or the second-line options. Next slide. Now, if someone's doing well on treatment, then there's no question you carry on and treat and extend them appropriately. But if someone's not doing so well with a poor response or a suboptimal response, then you're thinking of switching the management. So a number of different options are given here. I'll just highlight one to start with. Next slide. And symptoms of allergy or adverse drug reactions. So if someone has an intraocular inflammation following any of the drugs, this is documented clear intraocular inflammation. Next slide. Then, I mean, this is a personal thing. I would strongly suggest to switch treatment if someone has that, because on repeat exposure, there's a high chance of them driving into a more serious adverse event with inflammation. So it's something to be concerned about. We've seen a number of cases, so it's important that if they have an IOI, switch the drug. I think it's a sensible option rather than challenging the patient again. Next slide. What's more common as a reason to switch is whether there's a suboptimal response after loading or you're unable to extend intervals. So those are two real common factors that you would then switch treatment. And you can switch as early as after the loading phase, because the whole idea of this is to use the right drug. If we know what drug to use for the patient, then we'd rather do that at the beginning, but we don't, and there's no way to predict that. This way, at least post-loading, it would be useful. How many patients you got to build in your model, then that's in the next slide. So a precise study over nearly 2,000 eyes precisely answers that question, where 50% of patients had some level of fluid with aflibercept after loading. Again, it's, I think, 8 to 10 weeks was the window here. So it's something to think about. It may be in reality about 40%, 45% that actually switches. Next slide. So again, why switch? Is there any evidence for switching? That's commonly questioned because there's no real trial that actually looked at switching. So we looked at real-world data. So the UK data in Moorfields, we've seen patients on aflibercept 2 milligram who switched to faricimab. You're then gaining 2.5 weeks. Again, this is not local to us. In the Swiss data, which combine a number of different units, again, seeing on average about 5.8 weeks going to 8.3 weeks. So again, you're seeing the extension of intervals for patients who are frequent flyers. And you can really see the benefits of liberating capacity in this cohort of patients. Now, the extension data, is it 50% increase or is it just a 1 to 2 week? Is it a 2-week increase? We don't know, and there's limited data and extension beyond the 10-week intervals. So if a 10-weeker, do they go 15 weeks? Probably unlikely. They probably go to 11 or 12 weeks. So again, the value of switch is probably highest in the most frequent group. So if they're having 4-6 weekly injections, the gain is significant because you're literally reducing the number of injections by 30% or more, as opposed to a patient on or let's say 12 weekly intervals, and you're gaining to 14 weeks, you're not really changing much when it comes to that. So it's just something to think about how much you're paying for that extra bit. Next slide. How do you switch? Again, if it's disease control that you're trying to achieve, then of course reloading is probably necessary. But if it's durability, meaning you control the disease, but every time you go up to 6, 7, 8 weeks, fluid reactivates. In those cases, you may consider interval matching, and both drugs, Eylea 8 milligram and faricimab as second-line options, are now licensed for interval matching. So reload is not mandatory in that case. However, when you do switch, again, these are frequent flyers, and be very aware that I said all the significant variations in AMD, and I wouldn't jump to 4-weekly intervals at this stage. You'll probably do 2-weekly intervals to be cautious in this. Next slide. So when to stop treatment or pause treatment, I'm cautious not to say stop, because some cases it's pause. So pause treatment if you're on multiple maximum intervals. You can consider pausing and observing up to 2 years or longer. And this again to assess whether it reactivates. We know about 30% reactivates, and in the longer acting drugs now, I'll be cautious that 3 months shouldn't be considered the maximum interval. Some patients we're seeing may reactivate in month 7 of the injection. So be very cautious that the longer acting drugs have moved the boundaries for defining what's a stable AMD. Stopping treatment if they're doing badly, central scar, disciform scar, again, there's no dense cataract to contribute, etc. Then is the patient treated timely, treated appropriately? Is it their better seeing eye? So all these factors, of course, comes into the picture. If they're really poor vision, then again, the value of further treatment is very limited and probably causing more harm to the patient than anything else. Then obviously, I think it's sensible to stop treatment. Next slide. Now, for vein occlusions and DMO, will be fairly swift. The key features with RVO is the choice of treatment between anti-VEGFs and steroids. Both are first-line options based on NICE, but of course, it's a clinician discretion based on what we feel the risk of the pressures, risk of the cardiovascular risk, the cataract formation risk, and the impact this has, and of course, injection frequency, which is important. Need to highlight that for BRVO, ranibizumab, based on the NICE guidance and back when it was first introduced, Lucentis was based on trialing laser, if it's not suitable for laser. Again, that is now reflecting current practice. We use anti-VEGF first line in these cases. So this just reflects that. Next slide. So again, first line, aflibercept 2 mg biosimilar ranibizumab, and then if they don't do well and no change or worsening of vision, persistent or worsening fluid, or not incomplete resolution, then you're looking at second line options, which in this case includes faricimab. When the guidance was done, aflibercept 8 mg wasn't licensed for RVO. I appreciate it's just been licensed, but it's not been reviewed in this set of guidance. So it's a local decision to implement that. And of course, the use of steroids where appropriate. If the injection numbers are a problem, there's pregnancy, cardiovascular risk, a recent stroke, you may want to consider steroids if of course, depending on the lens status and the glaucoma risk for the patient. Next slide. So switchback, whenever you consider switches, I think you definitely need to consider a switchback. And again, if someone's failed 2 extended intervals and there's no clinical benefit, it's intentionally written in a broad way because clinical benefit is important. The patient notices an improvement, the vision is improved by a bit, the fluid, the anatomy of the OCT is better, then again, there is clinical benefit. We would keep. But if there's no clinical benefit whatsoever, then of course you revert back to the previous drug. I think that's entirely reasonable, unlikely but reasonable. And of course, considering steroid if you feel it's necessary. And of course, if you switch someone to steroid, you should be allowed to switch back. Again, depending on the reasoning, if you switch the patient from a steroid, from anti-VEGF to a steroid because of a stroke, etc., then you can switch back. Or if the patient develops problems or pressure problems with steroids, then I think it's reasonable to switch the patient back to an anti-VEGF that worked for the patient previously. Next slide. And again, similar concept when it comes to stopping treatment and pausing treatment. If they're not doing well, and that's a term that we use in RVO, if the retina is dry but thinned and atrophic and ischemic, and the vision is poor, then further treatments of limited value, so it makes sense to stop. But of course, ischemic CRVO, for example, or HRVO to that extent, be very cautious about the risk of neovascularization or NVI, NVG. So if the patients have paused or stopped treatment, then really do consider either close monitoring or PRP to reduce the risk of neovascular glaucoma, which none of us want to see. Next slide. And DMO, again, indication, center involving macular edema, which is causing vision impairment, and more than 400. Treatment is indicated or allowed. NG242 looked at patients with less than 400 is something to consider locally. Next slide. So again, similar concepts of starting with a biosimilar 2 mg of ranibizumab if you wish, either or, and of course, failing that, the second line options of aflibercept 8 or faricimab. And of course, if the anti-VEGF is not suitable, you have your Ozurdex options and Iluvian options in this case. Again, the choice of which one to use. Again, look at pressure risk, cardiovascular risk, lens status, injection frequency. Next slide. And post-loading, so again, you don't want to keep the patient on a drug that's not working. So if you loaded the patient, even after 3 injections, and you find that they're doing well or they're improving, again, this is commissioning guidance, not clinical guidance. There's a lot of options here, and the clinician, of course, decides what he feels best for that patient, and of course, with the patient's input. But if someone's doing really well and they want to carry on the same drug, that's completely appropriate. Someone's not doing so well, but there's some improvement, then there's a question whether you keep carrying on with the anti-VEGF, you switch anti-VEGF, or even you consider steroid if that's suitable for the patient. And of course, the patient is a poor responder, not doing well, hardly any response, then you really want to consider switching the drug to either steroid or an anti-VEGF, a different anti-VEGF, again, based on what factors. The patient's a young patient, phakic, high myope, etc. You might skew your decision to more anti-VEGF. If someone's pseudophakic, you might consider a different option with no history of glaucoma. Next slide. So again, the options are there. Switching, again, here you can see that it switches from anti-VEGF to alternate anti-VEGF in terms of, I think most cases you'll find it's because of lack of full response, because we know that with DMO, but also with injection frequencies here, if it's frequent, then you want to consider switching for the patient's benefit, if it's the right thing to do. Again, alternate drug class if it's suboptimal outcomes. Next slide. And steroids specifically, because you've got a cohort that have a high risk, a younger cohort who may be pregnant, again, a younger cohort, a cohort with diabetes who have higher risk of systemic problems like strokes, etc. You might want to consider steroids, and you want to switch back if allowed as well. And this is something we support. If you want to consider switching, you have to consider a switch back. So again, if someone had a stroke and you want to switch to an Ozurdex, again, if the patient finds it better with anti-VEGF, then after 3 months or so, you want to consider switching back. I think that should be allowed. Next slide. Again, similar principles. You can see the trend here. The part of the discussion when the discussion started was what criteria are needed, i.e. what aspects need to be focused on, and start, switch, stop was something they focused on, or start and stop initially, and then switch came in the picture. But you see, you can understand why most NICE guidance, etc., is all focused on starting treatment, which is clear. Stopping treatment has predominantly been clinical, and we all do this. I think what was suggested here is not abnormal and reflective of what we're doing in practice. So this is DMO, and it's a typo from my side. So again, similar to RVO in terms of patients not doing well with vision. If counting fingers with edema, we all know that the treatment success in improving the vision is very low and unlikely. And again, treating the patient unnecessarily may be doing more harm than good. Next slide. So again, in conclusion, the whole concept here from the group was to try to use the best value medicine for the patient, but also the system, so that everyone in the system will benefit. It's not just a select group and not just ophthalmology, but of course, utilizing the biosimilar where appropriate and the biosimilar savings, but also not forgetting it's not something that I think anyone anticipated for it to be a 90% biosimilar use. I think the final product of everyone, you will find a high proportion of patients still on longer acting drugs, because that is important to keep a balance between what's right for the system, the capacity, impact, and of course, patients. You don't want a patient to be on monthly injections. That's highly unreasonable and not appropriate. Thank you.
Thank you very much, Luke. Very comprehensive, covers a lot of questions that I had as well. So, I mean, this is all towards standardization of the medical retina treatment, so that, you know, in England and in UK, the treatment should be more sort of standardized. But you think that even this and other things that are coming in about reference drugs and, you know, values and all that, that will still create differences in the way we deliver our services. Just a short one, and then, yeah.
I think that reference price, I wasn't involved with the reference price, but actually I welcome the reference price because it allows savings to come back to the hospitals, the trust.
Mm-hmm.
Without that, I think it's harder, because it can be passed through, and then you're in a situation where zero savings come back to the hospital. So I think it was mainly designed to help that, but I think we have to also be cautious about the impact it has on independent sectors who don't have any background data to then build contracts. So I think that is tricky. I don't think everyone's following the reference price. In terms of reference price, it's probably a reference rather than a dictated price. So I think I'm glad that that's been proposed, because it does allow us to keep some savings, which is something we've been always asking for. But again, I think that allows that, but provided no one abuses it by trying to take advantage, because I think it may impact your future contracting in subsequent years if you use that. But I don't think any clinician will intentionally do that, because you're then harming the patient, which is something we've always argued about, capacity and numbers of injections. So I shouldn't think that would worry anyone, but you never know. Everyone can everyone can abuse different systems, and I strongly say we should do this for the patients and the system, not for any other reason.
Absolutely. Thank you very much. Can't see any raised hands. They've got limited view. But for the sake of time, shall we move on to the next speaker please. And if you have any comments, questions, please do write in the chat box. We will get back to you after consulting with Luke, if he can answer, if I can answer, if somebody else can. But please do, if you have any questions, do write in the chat box or email us. Thank you very much. So over to our next speaker. Thank you very much, Rebecca.
Thank you very much. So good afternoon, everyone, and thank you for inviting me to speak today. My name is Rebecca Derinola. I'm the lead contracting and commissioning pharmacist. I work with the Integrated Care Board in Kent and Medway, and I specifically focus on medicines optimization, high-cost drug medicines, with a specific focus specifically within ophthalmology. So thank you very much for having me. Next slide, please. Thank you. So I'll start just by setting the scene with strategic commissioning, and just really to understand overall just how the NHS England's National Medical Retina Commissioning Guidance, how it's, I guess, being adopted across the system and what really it's trying to achieve. And then to cover medicines optimization, biosimilars, and talk through some of the implementation challenges that some of us potentially might be experiencing. And then finally, with some of the core principles which support effective adoption. I also just want to ensure that I cover just with regards to the medicines pathways perspective, and just to highlight that I'll be specifically covering the commissioning, but not from the service commissioning, but specifically from medicines commissioning. So now looking at the NHS oversight, so just really I'm trying to understand overall where we currently were as an NHS and where we're currently going to as a strategic commissioner. So previously we were working towards a more oversight organization as an NHS, but now we're moving more towards strategic commissioning. So in ophthalmology, this shift is quite critical because medical retinal services represent some of the highest volume of outpatient activity in the NHS, and anti-VEGF medicines account for a significant proportion of medicine spend. So strategic commissioning here, really, the reason why I included this infographic is really just to show where we were looking at specific assurance, where we were looking at specific lines of data. And it's not the case where that's no longer important, it is, but we're really trying to move more towards a position as a strategic commissioner, which includes that strategic leadership and looking more at potentially the outcomes that are associated with the data that we currently have, using that information to help us to provide insights with regards to the policies that we currently have available. So making sure that we are using any of that data and insights to anticipate demand, ensuring that it aligns as well with clinical pathways, with national evidence, and ensuring that high cost and high volume medicines are used in a way that is both clinically appropriate, but is also financially sustainable for the entire system. And in order to achieve that, there's an importance about working collaboratively and working cohesively as a system, and that includes with several stakeholders. So within my talk today, really, that's what I mainly want to highlight, is an understanding about how we as a strategic commissioner work with other stakeholders, with clinicians, with our financing teams, and with the other pharmacists within the acute trusts and other organizations, to ensure that we have a holistic approach and ensuring that we get the best value from medicines. Next slide, please. So this particular slide just summarizes the 3 key disease areas that were covered within the NHS England's National Commissioning recommendations for medical retinal indications. So that included the neovascular age-related macular degeneration, and diabetic macular edema, and macular edema secondary to retinal vein occlusion. Now, although these are quite distinct conditions, the NHS England's intent was consistent across all of these three particular areas, and that was to support evidence-based clinical pathways that were aligned with NICE guidance and implemented through local commissioning and governance arrangements. So it's not about removing clinical judgment. And I think Luke quite nicely put that together, that these were commissioning pathways. So there's an importance about still having clinical judgment at the heart of these particular services, and when we are looking after patients and working collaboratively, not only with between ourselves and the consultants, as well as pharmacists within the acute trust, to ensure that we achieve that and ensure that the clinical judgment isn't removed as part of this process. So it's about standardizing the initiation, the monitoring, switching, and stopping or cessation or pausing decisions, so that patients receive consistent care right from a national level, regardless of their geography. So it's really just to highlight that we're trying to find a cohesive way of working together to ensure that we deliver the best outcomes and, again, the best value for the patients that we serve. Next slide, please. So now, looking at from the clinical pharmacy's perspective and biosimilars, so this slide mainly just brings together these three particular pillars that are quite pertinent to clinical pharmacy. So that's pathway optimization, medicine's value, and clinical governance. And that's really understanding about the way that we have basically standardized the approach of using high-cost medicines and high-cost management across the entire ophthalmology speciality. So with regards to pathway optimization, that's where each condition has a specific commissioning pathway, which includes that clinical evidence to support the best used for these particular patients and guides treatment sequencing, responses, assessment, and follow-up and new monitoring that's associated. The second is medicine's value. And that's where we're using multiple NICE approved options exist, as we know, and systems are expected to apply consistent value principles. So I know that there's particular reference that has also been made, and there's a quite significant discussion about the NHS England's document that was published that specifically covers the best value medicine. So it's really trying to ensure that that's adopted across the system. And this means that we consider the clinical aspects that are associated with these medicines. So that includes the dosing frequency, the administration burden, and the overall system impact. So it's not just about the acquisition cost in isolation, but it's really understanding and considering exactly how we utilize these medicines and the impact that it has overall. So this is understanding potentially the use of maybe slightly shorter acting agents and what the implication might be overall on the system, taking into consideration, just as Luke mentioned earlier, just about understanding that we might have a medicine that maybe in terms of its drug acquisition might be slightly more expensive, but it might give the opportunity for patients to reduce the capacity burden. There might be opportunities where evidence has shown that with treating with longer acting agents, we are able to obtain less frequent administration. So it's really just trying to find a particular point within all of the work that we're doing where we are able to not only utilize the medicines that have longer acting evidence of a longer action, but also to ensure that these are in terms of the acquisition and the overall cost of these medicines are acquired but are useful within the system, and we're using it in a particular way that's best for the patient. And each patient will have their own individual needs, and that's why we really don't want to remove that clinical judgment from the pathways and from the inclusive discussions that are undertaken within clinics. Now, we also cover specifically clinical governance, and I always try to highlight this within the network meetings that I facilitate within the region. And that's really just trying to understand that high-cost medicines, currently the bulk of the medicines that we use, which are high-cost drugs, they currently sit outside or excluded from the NHS payment scheme. And therefore, there's quite specific commissioning, assurance and reimbursement arrangements that cover those particular medicines, and those are aligned with particular NICE technology appraisals. So there's an understanding that when we want to implement these particular technology appraisals and utilize some of these medicines, we understand that there is a holistic approach that we are using. And rather than doing things on an individual basis, for example, per trust, we try to do things once and for all, so that we have a holistic way of moving forward as one unit and as a system. So that this includes the way that we ideally try to support the safe and consistent and auditable use of our medicines by applying that overall clinical governance and ensuring that we are using the data that we have available to support that particular approach going forward. Next slide, please. So now, this is quite an important slide. So this is where we're looking at the guidance and looking how it meets the reality. So even with clear national pathways, appropriate implementation, things can still be quite challenging, because we've got, for example, administrative burden. So that's the pressures that come as part of the administration. So processes such as, for example, BlueTech try to capture the data, but we are also trying to explore other alternative ways of potentially capturing outcome data and ensuring assurance. And we're also trying to ensure that the way that we capture that data is auditable, and we can place real a real understanding about what is going on in reality within the clinics, and the necessary evidence that will support any of the decisions and the insights that we make going forward, especially with quite high volume clinics. Within the region that I work in, we have quite a unique setup where we have not only acute hospital providers for ophthalmology, we also have our services some of our ophthalmology services covered by community providers. So there is an understanding that not all of the processes may necessarily work across both areas. So there is an importance of understanding the structure of whatever region that you're working in, and ensuring that within that structure, there's a holistic way of moving forward. So even though we have nuances between the acute providers and the community providers, we try as much as possible, again, through our network meetings, by having discussions about some of the nuances and trying to find commonalities and ways that we can potentially move forward as an entire system. So we understand and acknowledge that there's parts that might not work for all, but how are we going to still ensure that we work cohesively whilst acknowledging some of those differences? And I really feel that we've been able to achieve that within Kent and Medway. Even with regards to the NHS England commissioning guidance that was initially released, within Kent and Medway, we had our own wet AMD policy, which was, or wet AMD pathway, which was already published at that point in time. So we were quite happy to work alongside NHS England in order to support with some of the work that was being conducted in order to publish these commissioning guidance. And just as Luke mentioned, it's quite extensive work, but we were happy to participate. And in order to ensure that nationally we had a best way of moving forward, and a try as much as possible to have a holistic approach with regards to the commissioning guidance. Next slide, please. Thank you. So really, with this particular slide, I'm just trying to highlight that in practice, we understand that systems, there are sometimes some implementation challenges, but working holistically and working together, there's an importance about understanding some of the differences that potentially we might have, but also working together as a system. And understanding that the medical retinal guidance, it tends to share quite a few of those core principles of working in cohesion. So the first is the collaborative governance. So this is where, for example, with the particular structure that we have, which is acute trusts and community providers, pharmacists and commissioners working as one system, working as one unit to align the interpretation of pathways and high-cost drugs policies, ensuring that as a system, we are moving together in order to deliver the best value for the patients that we serve. So just to give a very quick example, there might be a particular concern that's brought about by one of the clinicians. We'll bring it to one of our network meetings and have a discussion about how potentially we are going to remove some of those bottlenecks. We might even engage with some of the the ophthalmology service commissioner, just to ensure that we are trying to work as collaborative as possible and trying to remove any of those impediments which might potentially have an impact on the patient. So as much as the network meetings are there to ensure that we have there's a place where the clinicians and commissioners can bring those discussions with regards to medicines and the pathways that we have. And especially with regards to the implementation, we know that medicines within ophthalmology, there's been quite a drastic shift, and there's been several new technologies that have become available. So this particular network meeting gives us that collaborative approach and ensures that we have that overall governance of how we're going to move forward as one system. The second is pathway adoption. So that's ensuring that biosimilars are positioned at first line options, just in line as well with the NHS England commissioning guidance. And those first line options are clinically appropriate, and they're also supported by clinical leadership and ensuring that the patient's experience is at the core of the work that we're doing, rather than it being treated as a kind of optional add-on. We try to ensure that throughout this entire journey, we put the patient at the center of what we do, and we put the patient's experience as part of that work through, as part of ensuring that we are delivering best value for the patient. What is the patient's experience within this process? So that also forms part of the overall governance. And the final one is really just the shared learning. So that's really working with the network and understanding that the network-based approaches, it allows us as a system to share our experience, and it ensures that we reduce duplication, where, for example, we might have a particular implementation in one trust and then the second trust and the third trust. Since we are adopting this particular medicine across the entire system, we try and do it once and for all, rather than having individuals. So forming a network meeting ensures that we are able to have those discussions as a holistic system rather than individual discussions. Any concerns might actually be occurring in more than one place. So this brings a system and a form of a meeting so that we are able to have all of those discussions once and have a unified approach of moving forward. So as I mentioned, this also helps to also gradually reduce administrative burden, because again, we're exploring other alternative ways of potentially adopting the new approaches and the new strategic as we're moving into now a new strategic commissioning body. We're trying to look at the ways that we utilize data and where we utilize data and how we can reduce some of those administrative burdens, as we mentioned, with systems like to capture data such as Blue Tech. So we are exploring other alternatives. And I think it's very important at this stage for us to have those discussions to ensure that when we move forward, we are having a system-wide discussion and we've agreed at a system level. So it's just really to highlight that there's a collaborative approach, which helps not only with pathway adoption, but also with shared learning. And next slide, please. Thank you. So mainly just to conclude, the NHS England medical guidance really is fundamental about supporting good commissioning for medicines at scale. but it's also important to ensure that we have the appropriate patient access to clinically appropriate treatments, and best value medicines are adopted consistently where the options are available. And governance and assurance and reimbursement remain robust and auditable. So please let me know if you have any questions, and I'll put my details in the chat. Thank you very much.
Yeah, thank you very much, Rebecca. It just shows that the whole, this shift in the way we work, it's not just sort of clinical patient, but the whole process and feedback to our commissioners as well, that what the intention was, whether that is being realized with patient benefits at the heart of this whole change. And yeah, as you say, very clearly, Luke, as well as yourself, that at the end of the day, it is what's best for the patients, which is what drives any change and standardization. There are a couple of questions, but I don't think they are directed towards you. It's more about where these services can be delivered in the community, in hospital settings, and various models are being explored at the moment. I think the we are just getting everybody to hear what everybody else has to say, and then the powers be can decide what's the best model of delivering these services. But thank you very much. I think I will get Nero to start her talk, if I may, please, because I think, again, I'm aware of the times and we want to give everybody their due. Thank you so much. Thanks, Nero.
Thanks, Bushra. So I'm Neera Narendran. I'm a medical retina specialist working in Wolverhampton, so not far away from where Bushra also works. We share the same ICB. And I think Bushra just wanted me to go through our experience in Wolverhampton of how we implemented the commissioning guidance once we had the biosimilar for aflibercept available to us. So I've sort of done it as a time scale with a timeline, and what we did at each step and the setbacks we had and how we overcame them. So next slide, please. Well, so we've heard this already, but as we know, ophthalmology services are under increasing pressure. We've got an increasing aging population, lots of chronic eye diseases, and there's a lot of high-cost medicines that we use to treat these conditions. And so it's all about striking a balance between achieving a high standard of care, but also maintaining excellent clinical outcomes and delivering a cost-effective service as well. So next slide. So I'll just touch on BEAMS. So BEAMS is the British and Eyre Association of Medical Retina Specialists. It's a new community of medical retina consultants and middle grade doctors and trainees, all interested in retina. Retinal disease, because we've not really got a group that represents us. So this was formed just over a year ago, and the idea is to sort of have a group that can be a voice for medical retina. And one of the first things we did was to put a positioning statement out after the commissioning guidance, because I think there was a lot of misunderstanding initially about the guidance, but I think Luke has actually clarified a lot of those points as he's gone through his talks. So next slide, please. So in essence, it's as things that Luke has touched on, just the reason to put the positioning guidance out, and the reason to have the guidance in the first place is really to try and reduce the amount of unwarranted variation in the delivery of IVT treatment. And it was also just to make sure that that delivery of service is done in accordance with the local patient demographics and the local service configuration and any local restrictions. So just to make sure that one size doesn't fit all, that it is important to take into account local restrictions and things that may limit the way one person might do it in one part of the country, but another person may be able to do it differently somewhere else. The second thing was the treatment of patients with good visual acuity. So Lucas touched on this already, that now that we have a drug that costs less, that it makes sense to treat patients who've got better vision rather than wait until their vision reduces. So just to push that, the fact that it would be good to treat these patients without having to apply for specific funding just to do this. And then obviously there'll be a great cost saving by using the biosimilar, and it was, but in but by doing that, there may be increased work needed around this, so increased number of injections, increased paperwork. So to try and make sure that some of that cost savings is reinvested back into the ophthalmology department. And then just harmonizing the treatment and switching of stable patients. So again, I think then there was some misunderstanding at the beginning about perhaps switching every single patient onto a biosimilar, even patients who are stable on other drugs, on non-aflibercept drugs. But it's just to make sure that if a patient was stable, they should stay on the drug that had given them that stability. And then just support for switching from the originator to the biosimilar. We wanted to make sure that, any sort of paperwork, in our case, sort of blue tech, these sorts of things that make the task more onerous, if it's possible to try and make these things a little easier for us, to sort of make the pathway smoother for us to be able to switch patients more efficiently. And then the last thing we were just talking about was just the optimal interval of treatment. Now that we do have these longer acting drugs, we are looking at getting patients out for well over 12 weeks, up to 16 weeks, sometimes up to 20 weeks. So the goal of 8 weeks now is perhaps not so much of a target anymore. And we felt that it would be good to try and aim for a 12-week interval and to switch if we weren't achieving 12-week intervals in the drug that a patient was initially started on. So next slide, please. So down to biosimilar implementation in Wolverhampton, we learned a few lessons when we tried to switch our Lucentis patients over to ranibizumab. We thought, we should get all the patients in for a face-to-face visit with a consultant-led clinic. We tried to get the patients in when they were due for their appointment, for their treat and extend appointment, which meant that, it was a very slow process because we had to wait for each patient to come in. So it took several months to switch our Lucentis patients over to our ranibizumab biosimilar. We didn't have many patients on Lucentis, but still, it took a long time. So because we learned from this, the planning for the Eylea to aflibercept biosimilar switch, that process started several months before the actual start date was anticipated. I've just put a little post up. We audited our Ongavia results, and we found that we were very happy with the results that we had with the switch patients. So we were very accepting and willing to try the biosimilar in the aflibercept group. Next slide, please. So this is the timeline, and I'll just go through each of these one by one. So in January of 2025, or probably actually towards the end of 2024, the discussion started with our pharmacy department about the biosimilar that will be coming towards the end of 2025. And then in February 2025, we started some meetings about how best to implement this, although this was a long, long way away from when we'd be starting. So a lot of it was quite theoretical because we didn't really know how it was all going to pan out. We didn't know when exactly we would have the biosimilar on our shelves here. So we'd sort of chat, we'd meet every so often. And then in July 2025, we started to work on a patient information leaflet because we thought it was important that we primed our patients who were currently on Eylea 2 milligrams that there would be a biosimilar coming and that they would be switched. So work started on this at that time. And if we could go to the next slide, please. So this was a leaflet that we put together, and this went through a few iterations, and I'll tell you in a couple of slides time, we didn't end up doing this. So next slide, please. So back to the timeline. So in August 2025, our group manager was very switched on and found there was an investor save initiative. So there was a way to actually get a bit of money into the department to try and help us with all the extra workload that would be required to switch patients over. So we applied for that. And then in September 2025, what we decided to do, instead of doing a leaflet, which is long and several pages and, not necessarily something that people would read, we thought we would do a letter to all the patients. So the letter was finally finalized and soon began to be sent out after that. So if we could go to the next slide, please. So this is the letter sent to every single patient who was currently on Eylea 2 milligrams. And in addition to the letter going out in the post, when the patient came to clinic from September onwards, we just checked whether they got the letter. If they said they hadn't, we would give them a letter, and they would make a note on MediSite that the patient received the letter, that they'd had a read of it, and that they didn't have any concerns. And the letter essentially said that we would be getting a biosimilar drug to Eylea 2 milligrams, and that we would be switching them over, and that they were very welcome to, to talk to us about any concerns that they might have. At the time, we didn't know which biosimilar we'd be getting, so we weren't able to put the name of the biosimilar on the letter, which we had a few discussions about, but we decided not to delay, just to carry on and not put a specific name on there. So next slide, please. So back to the timeline. So we then had to talk about consent, and this again went through a few sort of thought processes. We had a lot of patients on 2 milligrams Eylea, so reconsenting all of them would be a big job. And so what we decided to do as a department was to amend our SOP for injections, so that, and if we go to the next slide, please, we can see what we changed on the SOP. We basically said that any consent that was for Eylea 2 milligrams was equally applicable to any aflibercept 2 milligram biosimilar. And that way, when the patient did their checks, when they came for their intravitreal injection, the consent form for Eylea 2 milligrams would hold for any biosimilar. And that was approved by the trust consent lead and went to governance. And so with that actually saved us quite a lot of work when it came to consenting. So next slide, please. So we're on to consent. So then we finally had our biosimilar confirmed in September 2025, but it was not going to be available to us until January 2026, or even though potentially we could have started using a biosimilar from the end of 2025 when Eylea 2 milligrams went off patent. So we then had our risk assessment for the launch of aflibercept 2 milligrams and went through that process. And then things really started to hot up. We started to have meetings every 2 weeks with pharmacy and our group managers, and things were going fine. We had a bit of a hiccup trying to get our biosimilar name added to MediSite. Again, we were going round in circles. I don't actually know what the problem was, but for some reason it had to be added to some sort of database before MediSite could access it and put it on for us to start to prescribe it. In preparation for it to go onto MediSite, we gathered as many prescribers as possible, because prescription was going to be the other big job. Changing people who are on Eylea 2 milligrams over to what we were going to have, which we thought at the time was Yesafili. It was a biosimilar we thought we were going to have. So we included the pharmacy team as well, who were able to prescribe. We got them all trained on MediSite, so got everything ready so that as soon as we knew we had that drug on MediSite and we had drug in stock, that we'd be able to go ahead and just blitz a load of prescriptions. And Christmas came and went, and we got into 2026, and we were told on the 8th of January that the biosimilar we thought we were going to have was not going to be available. So that was a real setback. But with lots of emergency meetings, we decided we would go with the alternative that was approved for our region. We made sure that we were going to get that on the shelves for the weekend, so that over the weekend, this is the 10th and 11th of January, Saturday and Sunday, really just a couple of us just prescribed over the entire weekend and changed all those prescriptions over. So we had to make sure we were definitely going to get that drug before we did all those prescriptions. And then we were actually able to give our first Afqlir injection on the 12th of January. So this was actually a week ahead of schedule. We didn't think we were going to start the biosimilar switch until the week after. So we started a week ahead. And if we go to the next slide, please. And it was very, very successful altogether. So really what we had done was kept all the prescriptions ready. We had documentation on MediSite from patients who'd been attending from September up until January that they were happy to be switched when the switch happened. We haven't had any patient or staff concerns, and so far, touch wood, no supply issues. We were able to realise our costs earlier than we thought we would. And all the costs so far have been directed towards our CIP. So we've not actually seen anything back in our ophthalmology department as such. but they've been realised against our ophthalmology department CIP. And actually, just this morning, I just got from our finance department our cost savings. So we saved almost £500,000 just in the 25 to 26 financial year, and another 150,000 in month 1 of this year. So really well on track with the switches. So it's actually, I think there was a lot of anxiety, but we worked together well as a team. And I think we could only really know how we were going to do it towards the autumn, really. But there was quite a lot of chatting, cost improvement program, I think, or process, I think. So basically cost saving, putting money back against each department. So the next slide, please. So the next steps, I think, is just so we've switched our existing patients. It's just really discussing about, what support we might be able to have and reinvestment back in the department with implementation in any new patients. We are using it for some new patients. Thank you. We are using it in some new patients at the moment, but again, it's very much dependent on their clinical features and their presentation and which disease they have. We are filling in blue text for the biosimilar drugs, but it is an extra step and it does require some labour. So it'd be nice if that process could be removed. But at the moment, that's an ICB decision, so something that we might have to carry on discussing with them. And again, like we did with Ongavia, it would be nice to audit our biosimilar results with aflibercept in the switch patients. We'd anticipate that everything should still be maintained. They should be very stable, but it would be good just to make sure that things are going as we think they are. We certainly haven't had any issues with safety with the biosimilar switch. So I think that's it. I think I've got one more thank you slide, and that's it.
Okay. Thank you very much, Nero. Yeah, so a lot of work. I mean, the switch is not just you flick a switch. There is a lot of work from clinicians, from the whole team that goes into it, and we've done it. We are in the process of doing this and reshaping things, but it's very reassuring to hear that there have been no safety concerns, but these are early days, so the results will show when our audits start coming in, and even the nod, I would put a little sort of plug for them, that once the nod data shows whether the results, visual outcomes, and number of injections, we're realizing what the NHS commissioning set out to achieve. So thank you so much. And yeah, no money back to us either. All goes towards SIP and it disappears. So thank you very much, Neera. If there are any questions, we will direct them to you afterwards, but great. Okay, so now we've got Anne-Marie, who is going to talk about UK Ophthalmology Pharmacy Group, and a little sort of nod to we had one long time ago, Lucy Titcombe, our specialist ophthalmology pharmacist, but no longer that position. So Anne-Marie, over to you.
Thank you. And thank you so much, Bushra, for the invite to talk today. So a little bit of a different topic. Today I'm going to speak about the UKOPG, the UK Ophthalmic Pharmacy Group. So I'm Anne-Marie Gocher. I am the lead ophthalmology pharmacist for University Hospital Sussex, and I co-chair the group with my colleague Lloyd Thomas, who's based in Liverpool, is the lead ophthalmology pharmacist there. Next slide, please. So who are we? We are the UK Ophthalmic Pharmacy Group is a national network of pharmacy colleagues who specialise or have a special interest in ophthalmology. And our aim really is to share knowledge and best practice across the network to ultimately improve ophthalmology clinical care for our patients. And we support each other with ophthalmic queries via our forum, and we strive to promote ocular health and the work of ophthalmology pharmacy teams nationally. So the UK OPG was founded back in 1994 by a small band of dedicated pharmacists, of which Lucy Titcombe was one of the originals. And over the years, the numbers grew to above, at times, about 200 members, I believe, and they had international membership across the globe. And for various reasons, in the latter years, and the impact of COVID didn't help, and the group kind of dropped off in activity. So when I came on board as co-chair, we decided to relaunch the group in October 24 with our first in-person meeting in Brighton since pre-COVID. So we discovered there was a great appetite for the network amongst our pharmacy colleagues, because ophthalmology is a very niche specialty in the world of pharmacy. And our colleagues, our esteemed colleagues in Moorfields, are in the very unique position of being in an ophthalmic specialist hospital surrounded by, ophthalmic colleagues, whilst pharmacists in other trusts, usually across the country, they might be the only pharmacist who supports ophthalmology for the whole trust, and often it's not as a dedicated role. So the group really provides, that much needed support for colleagues in this very vast and complex specialty. Next slide, please. So since that relaunch in October 2024, the membership has grown from about 50 active members at that time to over 160 across all nations now of the UK and Ireland. And we have meetings in person once a year and virtual meetings every quarter, where we update members on activity of the group and discuss, current topics of interest, new guidance and developments in ophthalmology. We created a new platform for the group on NHS Futures, and we have a very active forum on there, on the group, which members find really valuable for asking questions and accessing information and guidance on practices in other trusts across the country. And this is a really valuable resource, especially for some of our more inexperienced members. Having a look at the data at the back end of the platform, we average at about 300 visits per week from our members, so quite an active membership. And last year, we were also contacted by our colleagues in the National Optometry Group, who expressed an interest in joining because some of their members have or are obtaining their prescribing qualifications, and thought it would be useful to link in with pharmacists and connect. So in the spirit of MDT collaboration, we've welcomed optometrist members to the group, and have been joining since last year. Next slide, please. So since the relaunch, I was very keen to find out what was happening in ophthalmology pharmacy nationally. So we devised a survey towards the end of last year, and we're very grateful to the UKOA for helping us to share the survey amongst their membership. And we also shared the survey through the Chief Pharmaceutical Officer's office. So the objective really was to kind of take a snapshot of the current state of ophthalmic pharmacy in terms of education and training for colleagues supporting the specialty, looking at whether there was dedicated funding for specialist ophthalmology posts, what opportunities there are for career development in the specialty, and integration into the ophthalmic MDT. So we know this is a very vast and complex specialty, and an understanding of the current picture we felt would help us to review development of education and training materials for our colleagues and lay the groundwork for progressing with creating ophthalmology pharmacy national standards in the future. Next slide, please. So the preliminary findings from the survey. So we had 49 responses from secondary care trusts across England. 28 out of 49 were not tertiary centres. There was a dedicated pharmacy ophthalmology staff exist in only 34 out of the 49 sites, meaning that 31% have no dedicated ophthalmology pharmacy support. And the feedback within the survey from people was that the consequences of not having a dedicated pharmacy staff led to governance gaps, unsafe or delayed prescribing workflows, inefficient reliance on senior pharmacists pulled from other specialties to deal with queries, and an overdependence on generalist dispensary teams for specialist checks. And that really highlights, again, the average training score when we asked about training and induction into the specialty, scored at only 1.8 out of 5 for satisfaction in that, showing really a major deficit in national training resources. And when asked, only 4 out of the 49 respondents to the survey reported having any kind of ophthalmology training for their role. Next slide, please. So in summary, the survey really found a significant mismatch between workload and pharmacy capacity in ophthalmology services across the UK. And really there's a strong national appetite for training, for standards, and for dedicated roles. And there is a substantial risk associated with the current kind of fragmented and inconsistent model of pharmacy support. And really what we need is a kind of concerted, coordinated UK-wide effort to improve governance, standardise care, expand training, and strengthen the ophthalmology pharmacy workforce. Next slide, please. So if you don't already, I would really encourage you to get to know your pharmacy team, because they are experts in medicine and can really add value to the MDT and give a unique perspective and support with patient care. So we are a safety net in terms of safer use of medicines, and we know there's so much evidence out there for better, safer patient outcomes and experience when pharmacists are involved in the MDT. They can also support clinicians in terms of navigating the kind of sometimes very complex pathways for formulary and governance to help the teams expand their treatment options and pathways for patients. As of this year, pharmacists will be coming out from their undergraduate degrees as qualified prescribers, and there are many pharmacists who have undertaken prescribing qualifications who can contribute to prescribing medicines. And we already have colleagues, including myself, who work as part of specialist uveitis teams, for example, helping to support with management of patients on immunosuppression. So as we've been talking about today, you know, we all look to make the best use of our resources. So don't forget about your pharmacy team in terms of consideration for upskilling to new roles and expanding practice within the multidisciplinary team. And as we've heard, you know, pharmacy is usually heavily involved. I know I was with the biosimilar switch and with coordinating the response to the national pathways in terms of anti-VEGF treatment. So if you're not involved with your pharmacist, find them out and get them to help with your ophthalmology team. Thank you very much.
Thank you, Anne-Marie. Yes, you know, a very useful part of our multidisciplinary teams and the extended roles, really, and we need to sort of make more use and make people aware of this resource that exists. So thank you very much. We have got a question from Rob. Over to you, Rob.
Yeah, thanks for that presentation. My ears spiked up when you talked about the training and lack of training around. I've often wondered about the level of training pharmacy have around drops compliance and compliance to kind of how people take eye drops and things like that. Would you say that that's missing around, you know, pharmacy being kind of taught around demonstrating and showing people how to take eye drops appropriately, and then obviously whether people are adhering to their kind of management plan? Would you say that was a gap?
Yeah, so I think ultimately, generally, there's an ophthalmology gap in general, and you know, we're from the survey, we've really found from our colleagues that it's only a vast proportion don't get any ophthalmology specific training and just sort of learn as they go on the job. But also we've discussed as well, you know, Lloyd and I have discussed about, you know, the lack of undergraduate, and there's very huge gaps in undergraduate pharmacy training as well, where they only get very minimal even just touch on ophthalmology, and there's a huge gap, I think, across the board, especially with our community colleagues as well, where there's a lot of, you know, movement of care into the community and patient first, and there's a real lack of confidence. And Lloyd and I just had a stand with the UKOPG at the Clinical Pharmacy Congress just this past weekend, and we had colleagues approaching us saying that very thing. You know, I don't feel confident when someone comes into my pharmacy with a red eye. I don't know what questions to ask them. I don't know when to refer them. And we very much were promoting the basics of getting the drops into eyes and showing pharmacists how to instill drops, and to promote reviewing installation of eye drops in the same way that people have looked at inhaler technique. So that was a huge thing, you know, for inhaler technique, you would check that. We were promoting, you know, checking eye drop administration technique. And there's a huge gap.
I do wonder if is there anybody on from Moorfields? They did a campaign, I believe, pre-COVID around know your drops, and I think I don't know where that's gone. I don't know whether that's still a thing at Moorfields, but I know that was something that when I was looking into this whole area of compliance and drops, I came across that Moorfields work, and I do wonder if that's still going or if it is something that we need to kind of revisit as a sector, especially in my view, in relation to the eye care support pathway and making sure that people are better complying to, drops and treatment regimes and things like that. So yeah, I don't know if there's any Moorfields people on here about whether that's still a thing. Know your drops.
Absolutely, yeah. It's an excellent piece of work, and I was in touch with the guys who created that a few years ago and tried to implement a clinic alongside my glaucoma consultants with that very thing in mind. And I'm hoping we've got a new ophthalmology specialist pharmacy technician we're interviewing for next week. So I'm hoping that we'll be able to take that concept and develop it in the trust.
Yeah, just to add to that. Yeah, thank you very much. Thank you. I mean, various departments have their nursing and other sort of allied health professionals who are in the department, and they sort of, again, try to explain to patients compliance, attendance. You have role of ECLOs there as well. Again, reiterating that, compliance with treatment and with attendance and its importance and the severity of their disease being sort of, requiring this level of patient education and involvement. So yeah, great. So we had a very comprehensive discussion about medical retina, all the therapies, the medicine optimization, implementation, which so far, the whole country is sort of engaged, and we want to realize the cost effectiveness and keep the balance between that and good patient outcomes. But as was mentioned by many, that auditing our results and actually knowing how we're doing is extremely important to see where we are and where we are heading with all these changes and reshaping of our pathways. So if there are any other questions, happy to take them. Some of the questions, they are in the chat books. These are more of government, Department of Health, strategic level questions. Who's delivering services where? I mean, UKOA is a platform where we want to collaborate. We want the whole of ophthalmology to be involved in providing care for our patients, but governance and policy would dictate all that. So just to say thank you very much once again for joining us today. Very, very useful discussions. Please join us for future meetings as well. Put your ideas down, please, for any particular themes that you're interested in, any work that you want to showcase for other members. We are very happy to take these suggestions. You can pop them in the chat box or use our inbox to put your suggestions in, because we are a membership group, and what we do and our output is governed by what our members would want to hear and listen. So this year's the two virtual meetings, please do join them. One of them around training of all the workforce. It's going to be very, very interesting, and the updates from Northern Ireland. As I said, the July meeting where we are looking at work with NHS England and our roundtable. It is going to be very good. It's fully subscribed, but you can, if you're interested, please, we can put you on the waiting list. If we have any people who are unable to attend, we would be happy to accommodate. But a lot to look out for this year, and we're working on agendas for the next year as well, and would be very, very happy to get suggestions. So a question for aflibercept 8 milligram on RVO. We'll get Luke's reply to that as well. But I think once it was approved after the document was released and the commissioning information came out. But yes, it's absolutely NICE approved and should be part of the pathway as clinicians and departments decide. So thank you so much. I will give 2 minutes back to everyone. Thank you so much. See you guys, unless anybody's got any last minute questions. No. Thank you. See you guys. Thank you. Bye-bye.
Thanks, Bushra. Thanks.
Thanks for
Bye.
joining. Fantastic. Thank you.
Thank you, Bushra.
Feedback, please. Thank you.